Hello, good evening, good afternoon, good morning, good day, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David Wigan. I'm a professor in the Medical Education, Research and Development Unit of the Faculty of Medicine at the University of Malaya. I'm also the past director of the Faculty of Surgical Trainers of the Royal College of Surgeons of Edinburgh, who have approved our teachings and offer CPD points together with the Academy of Medicine of Malaysia. If this is your first time joining, thank you and welcome. If this is a follow-up, thank you for persisting, and I hope you're enjoying this series as we focus particularly on stitching skills. This would not be possible if it weren't for the support of the Academy and IACO and Dr. Aprajita, who is actually in New Delhi. We are coming to you live from Kuala Lumpur, and at present it's 9 o'clock in the evening. Thanks to IACO, we have now 396 registered participants, and just under half of those are active and come back again and again. We are reaching countries like Afghanistan, Belgium, Brunei, Cambodia, China, Egypt, Ethiopia, India, Libya, Mexico, Myanmar, Nigeria, Oman, Saudi Arabia, Sudan, United Arab Emirates, and the United Kingdom. Thank you very much indeed for following, and thank you for joining from around the globe. It has been difficult to think of an appropriate time to organize this session. We come to you live at 9 o'clock in the evening in Malaysia, and that is a convenient time in Malaysia for those who are returning from prayers in the evening. If you feel there is a better time that would suit you, considering we are across numerous time zones with the difference of 13 hours, do let me know and we will try and accommodate. Thank you. So this evening is all about joining. We have discussed to date the principles of stitching using one object and in one plane. As soon as we start bringing two things together, we need to consider the fact that we're now operating in two different planes. Previously, we have emphasized that if you put your fingers together, thumb to thumb, index finger to index finger, middle finger to middle finger, ring finger to ring finger, and little finger to little finger, that our stitches need to be equal and opposite. Failure to do that, we have a dislocation. But as you put your fingers together, do look at the creases at the phalangeal joints. They are aligned, and they're aligned as a wound would be aligned if you're equidistant from the edge. And if you're not equidistant from the edge, you get a slip. So the problems with failing to attend to the basics as we've described so far are twofold: dislocation and a slip. Now, we need to apply those principles now to operating not just in one plane, but two planes, as we demonstrate how we put a patch on a fusiform incision. Remembering that as a fusiform incision, that the vector from that side is 90 degrees, the vector from this side is 90 degrees, but when put together, they subtend an angle, as previously demonstrated, between 85 and 90 degrees. You cannot therefore force your needle through one side and then the other side and expect it to not damage the tissue. The other thing about this evening is once one starts using a stitch to join one thing to another, we now have to think about two other important elements. Firstly is the principle of stitching. The principle of stitching needs that you stitch towards yourself. That is, from further away towards yourself to avoid tripping over the suture. And secondly, you need to now think about the assistant. But we're going to deviate as I introduce another metaphor, as I like doing with the Black Belt Academy. You see, joinery is a part of woodworking that involves joining pieces of wood. Engineered lumber, synthetic substitutes, laminates to produce complex items and structures, buildings, chairs, furniture, and they employ many fasteners, bindings, or adhesives, but otherwise use wood elements such as dowels or plain mortise or tension fittings. The characteristics of a wood joint are strength, flexibility, toughness, and appearance, not too dissimilar to the joints that we are going to think about when doing a survey. And they derive from the properties of the materials involved and the purpose of the joints. Again, not too dissimilar to what we are thinking about in survey. Therefore, different joinery techniques are used to meet different requirements. Again, not too dissimilar to surgery. For example, joinery to use to construct a house can be different to that used to make a cabinet or furniture. And in British joinery is distinguished from carpentry, which is considered to be the form of structural timberwork, as opposed to joinery and cabinet making, which is the fine woodwork. So many traditional joinery techniques use distinctive material properties of wood, often without resorting to mechanical fasteners or adhesives. Now, what's interesting, whilst every culture of woodworking has a joinery tradition, wood joinery techniques have been well documented and celebrated in India and China and European and Japanese traditions. And because of the physical existence of material from India and Egyptian examples, we know that furniture making goes back several dynasties. And the dovetail joint that we recognize and you will be familiar with is over 5,000 years old. This tradition, together with other later Western styles, has continued. And in the 18th century, a chap called Diderot included 90 different illustrations in his encyclopedia on how to join wood together. And this was published in 1765. Whilst the Western techniques have focused on hiding the joint, the Eastern societies did not try and hide the joints. In fact, the Japanese and Chinese cultures required the use of hundreds of different types of joints, and they've made this now an elaborate art that the joint itself has become complex and art in itself. The reason is that nails and glues wouldn't stand up to the vastly fluctuating temperatures and humidity as I'm experiencing in Kuala Lumpur. And they are the conditions of most Central and Southeastern Asian countries. The other thing is that the woods found in China and Japan have high resin, and despite using alcohols and cleaning agents, you cannot get rid of this. So they've evolved a join without glues, without nails, but this has now become the beauty of Japanese joinery. So, as the trade modernized in the Western world, to help evolve speed and simplify and improve joinery, we've seen glues and new mechanical techniques, including biscuit and domino joints and pocket screw joinery. And I relate this because I think it mimics what we have seen to be honest, in surgery itself, that we have gone down the route of staples and mechanical devices. But the point is, it all depends on the type of tissue. And the joints and stitching one thing to another need to be stable and have strength. This must be taken into account when putting bits of wood together. Otherwise, the joint will fail. See, gluing boards with the grain running particularly perpendicular to each other is often the reason for the splitting of boards or broken joints. And some furniture made in the 18th century, while made by master craftsmen, did not take this into account. And the result was that many antiques may suffer from a broken bracket, which is often attached back with blue block, which ran perpendicular to the bases and failed. Modern woodworking, it is even more critical, as heating and air conditioning causes severe respiration demands between the environment and the wood interior fibers. This respiration demand, I reflect, is the oxygen demand of the tissues and our ability to breathe. You see, all woodworking joints must take these into account and allow for resulting movement, as many of our joints in surgery too must take this into account. See, each wood species has a general respiration rate, a generally assumed time length for acclimating a board to locate its 1 year per inch of thickness. So 1 year per inch of thickness that's how long the wood should breathe for before using in joinery. In preparing raw wood for eventual usage as in furniture structures, one must take into account uneven respiration and changes in the wood dimensions, as well as checking on cracking and splitting. You see, wood is stronger when stressed along the grain longitudinally than it is stressed across the grain. Wood has a natural composite material, as does tissues, and parallel strands of cellulose fibers are held together with a lignin binder. And these long chains of fibers make the wood exceptionally strong by resisting stress and spreading the load over the board. Furthermore, cellulose is tougher than lignin, a fact demonstrated by the fact that it's relatively easy to split wood along the grain compared across it. So the other thing to bear in mind in joinery, as with tissues, different species of wood at different people have different strength levels and different nutritional status and different levels of collagen and elastin. And the exact strength may vary from sample to sample or person to person. So species of wood and people differ on the density of tissue and the amount of collagen and elastin or cellulose strands. So the principles, what struck me looking about joinery and the craft of joinery is very much like surgery. We do have to take multiple elements into account. And that is what we're looking at this evening, particularly as I consider we're going to stitch a patch to a banana, one being a piece of material, the other being organic. Not infrequently found in vascular surgery and cardiac surgery, but we have to not only appreciate that we're working at two different planes, but we now got two different types of material being joined together. As we do this, we need to consider our basics. 90 degrees to the tissue, 90 degrees across what you want to stitch, and 90 degrees into what you want to stitch. Now, the banana is quite forgiving if you're not 90 degrees, but as you've seen already, it will tear or split. whereas the material with a whopper weft is totally unforgiving if you're not 90 degrees to it. So the important thing about organizing your stitching is to think and have a method of how you join one thing to another. And it's either outside to inside, inside to outside, or inside to outside, outside to inside. The important thing, it's in to in or out to out. If you go out to in to out, one will evert. If you go in to out to in, one will invert. The important thing is, if you look at my hat, is that the join should not reveal any stitches, gaps at all. And in fact, the join should be such that you've got endothelium to endothelium and mucosa to mucosa, because we know that blood, when in contact with anything other than the endothelium, or if you've got an exposed mucosa, one, the former will have clot, and the latter potential infection. The other important technique that we're going to go through with this is the concept of parachuting. Now, parachuting, one needs to think about the orientation of the suture. And one way to think about it is to keep to the inside track. We will now go over and demonstrate these principles to you. I will just call upon my assistant, who is going to come and offer a hand. But I'm first delighted to share with you that we have taken receipt of the Black Belt Academy of Surgical Skills set of instruments. That is our logo, accredited by the Royal College of Surgeons and the Academy of Medicine of Malaysia. I demonstrate this because one of my major concerns is simply this. Surgeons should not blame their instruments, far from it. But however, Sensei Caddy and myself have noticed the huge number of instruments that have now become available to training surgeons. And quite frankly, the quality of those instruments are not good at all. If the instrument, as previously described, needs to be extension of your fingers, you need to be able to feel the opening and closing of the instrument and also hold it with a lightness of touch. We have these instruments produced, a lovely rider needle holder, together with a DeBakey forceps with a non-crushing tooth in the middle to enable you to grasp them, and also a pair of Macintosh scissors. And if you could hear the sound, but you can feel the blades cutting. Beautiful. I am looking towards ensuring that people who join the Black Belt Academy and our face-to-face meetings in Malaysia will start soon. Every joining member will get their own set of instruments in their own pack, and there'll be no excuse to not to practice. Check the plug at the bottom. So we are now going to put this patch, and we're going to put it in this fusiform incision in the banana. Now, I've deliberately used a piece of stripy cloth because I want to emphasize the direction and the vectors as previously described. You'll note that although the tip of this is pointed, one's patch needs to be rounded. If you put a point into that point, it will bleed and would not hold. So the patch itself needs to be rounded. The diameter of the patch, you see here, is 1, 2, 3 stripes. But I've got 2 stripes either side because I need to incorporate the patch to take account for the depth and the stitching. Remember, as we do this, our vectors of 90 degrees, that is down the middle, that is there, and that is there. And as a rule, I usually recommend that we go 1, 2, toe or heel, 1. It sounds like a rhythm of a dance. 1, 2, heel, 1. I wouldn't recommend putting more than 4 stitches in to parachute down because the tension taken up on the parachute means that those 4 stitches, if it was more, start tearing out of the banana. So I've labeled this on one side, outside and inside, outside and inside. And it's important that when you're stitching anything, you're thinking outside, inside, inside, outside. And the orientation of your sutures should be always considering where you are on the anastomosis. So I'm using a 4 over here. I'm using our new needle holder. Remember, when you put a needle on, before you make any stitch whatsoever, it's important that your alignment of this needle is correct. That is, on the tip, so there's no space between the shaft and the needle holder, just on the halfway. And that angle there represents the displacement of my wrist from my elbow as I stand. In other words, that is 90 degrees to the tissue. And if I pronate back, that is pinpricking and 90 degrees to the tissue. That is the first start of any stitch. Now, this is going to take a number of stitches, but that attention to detail and placement and pickup of the needle is vitally important at every single step of the procedure. Otherwise, you'll end up with this being scrambled and a poor join in general. So I am going to just put a rubber shot on the end of this, and I don't have a rubber shot, so I'm going to put another needle holder on the needle in the other direction. And this is where it is important now to have an assistant, because I am going to get my assistant to hold my patch and follow. So I'm looking at the inside of the patch, that's the outside of the patch. 1, 2, middle and down. And at all stages, I am actually having to think about and orientate my suture. So through the patch, 1, 2, middle, 1. And I'm now going to ask my assistant to follow. Now, you'll note that I'll just take the brightness down a little bit, so we hope we can see the suture. I am now on the inside of the patch. So I am now aligning, place, point, and rotate. And remember, one actually delivers the needle to the point that you can pick it up. And what I've done there, I'm going to focus in a bit further. I've demonstrated the first principle of stitching. I've come to the outside. You see I'm on the outside, but I need to be on the inside. So when one's stitching, keep it to the inside all the time, because then you're not going to trip over the suture. So that is the inside. You can see by holding it out the way, that stitch is held out the way for me, and I can keep the inside. Again, quite often, your fingers are the best forceps to use. And certainly when stitching vein or artery to the aorta, I would actually use my fingers to hold the artery or the vein, because as I've explained before, you're putting 7 million Newton meters squared of pressure through the forceps. So line, place. That's giving me the situational awareness of spacing. I can check my radiality and the direction. I then need to adjust my body position, just to hold the sutures straight for me. Remember to keep your suture straight and rotate. Take it through, keep to the inside, pick the needle up from the inside and relax. Now, just to point out as an assistant, Alistair's got his finger and thumb opposed in the direction that I've taken the suture. He does not pick up the suture until I've held it with appropriate tension in the direction I want it to be held. And this is an important point in surgery. It's a lateral hold and not a pull. It's important that we go to a lateral hold and not a pull. Oopsie, even that actually is pulled out of my banana there. So just gently. Oopsie, and there I've made a mistake. As I concentrated on doing that talking, I've forgotten to go to the outside. Just keep it steady. So it is a process that you have to think about all the time. So I was on the outside of the banana. I need to go to the outside of the patch. And now I'm on the inside of the patch. And now I need to go inside the banana. That's, and now I'm on the outside of the banana, and I need to go on the outside of the patch. Now, when you're practicing doing this, I recommend that you definitely use an assistant because otherwise you'll get tangled. Keeping to the inside, you'll see that my sutures are held out the way by the patch and proper retraction. Having come round the corner now, I can come through the banana forehand. Now, this is an important skill, is taking this down, you take it down, relax it down, and you take up the tension. Put it up gently, let me do it, I take it down, you take up the tension. And this is the process of parachuting. If you pull both ends, you'll run out of suture. And only once you're almost down, you can then pick the suture up, let go of that patch, undo that, and bring it down and take up the tension. Now, if I had put more than 5 sutures in there, I'd find that I would be tearing the banana itself. Okay, would you mind following that, please? This element of stitching now requires that you need to learn how to use your assistant. And a bit like a musical instrument, if your strings are loose, you'll find you cannot play the instrument. So we need to actually keep the tension, and that is why we need stays. So hold up laterally, please, here. Finger and thumb towards the suture. And now I can think about I'm on the outside. And this is really as an exercise, challenging your thinking on the haptics. Just relax. Just gently hold out to the side like that. The other hand. And that now gives me an opportunity to actually think about the placement. Place 90 degrees, and I'm going to rotate. Once I get going, you'll see that the two edges start to sit together. When the two edges start to sit together, I'll note, keep tension on that suture. And you'll find, as an operating surgeon, that with a new assistant, that you do need to think about directing them and maintaining the tension all the time. Let go. Okay, there you go. Good. You'll see now that a gutter is actually appearing. Because I'm using material, I can probably go through both, but I'm holding the two together, so I can go through them both and rotate. Did I actually place it and ensure the vector would say? That's what I need to do each and every time. Forceps don't grab the suture, but they help me align it as it has been taken down. Place it, and I'm going to take it through that side. Keep the tension on the suture, please. And this is for an operating surgeon. Again, very important to think about is how you are directing the assistant. Now, some surgeons, when doing this, especially under stress or difficulty, they start barking at the assistant, which is totally and utterly inappropriate because the concentration of the assistant is going to disappear. So when you're practicing, do put marks on. Thereafter, look at your own spacing. Place is space. Look at where you're pointing. Pointing gives me that precision through, and was that 90 degrees across the edge? Perhaps not. But each time I'm doing this, I'm checking and looking for all the elements as we have described. I'm looking for that sort of spacing. I'm looking for that pointing now exactly where I want it to stitch. And I'm going to take the next bite. I'm checking 90 degrees to the radius there, having in a point, take it through, and probably do it in two. I'm going to take it for a moment because I'm going to run out of space. Just hold that for a moment. So once you get to this element, I'm now going to cut this to the appropriate length. And curve it around. So only when you get to this stage, oh, I do like these scissors that we've got. They are cutting beautifully well. Okay. Thank you, follow that. So, place, pointed exactly where I want to go, and I'm going to rotate it. Lost control of the needle there, so I'm going to do that again. Just looking at this. Point it in. The contrast between the material I've got here and the banana is actually forcing me really to think about the haptics of both the banana and the material that I'm using as a patch. Because this is an awkward angle, I'm going to do it in two. I'm not going to get the alignment otherwise. I can use the forceps in this circumstance to hold the needle such that I can pick it up, but I'm not using the forceps to deliver. Just hold that gently your direction, and that holds the flap out the way. I'm now stitching into my right shoulder. And as you know, for a right-handed surgeon, stitching into my right shoulder means that I now have to change direction and ask my assistant to use the other hand such that I can come around the corner. And again, I'm going to point to get through the material. I'm going to place to make sure the placing and spacing is right. Rotate it out on the vector. Use my forceps to ensure it's sitting down well. And I think I'm going to find I'm going to run out of suture along this edge because I haven't given myself enough. But it's an interesting exercise to do. And if you're practicing stitching, it is testing your orientation. It is also testing your needle skills, not only through the material, but through the banana. And even because the two edges are not sitting together, I'm doing it in two. Materials from a shirt, an old shirt that I had, that is now being used as part of the ironing process. And at each stage, one's thinking, place, point, rotate. It's now starting to line up, and I can probably take that down. If I take it down into banana, I didn't like that. Let's get it through. It's not ready yet. So at each stage of stitching, there are no shortcuts. And I'm talking aloud as I'm doing this because I'm wanting you to think yourself as you're stitching, to do the same narration. A colleague of mine, a cardiac surgeon, and he was stitching, he would actually likewise say, good shot, good shot, good shot. And he was always reflecting on action with his stitching, each and every stitch of a coronary anastomosis. Thinking about a patch, it should not be taught. Patch needs to be, now I've run out of a suture there, and that's because I didn't take enough through. This side, I could probably come through from inside outside, but that's going to, for vascular anastomosis, compromise the integrity because I haven't got outside in. So part of your planning process, I've got 2 stitches left there, and I'm not going to get it for that end. The important thing is that you've got enough material that sits inside there as a patch. We have gone round on vectors all the way around this banana. And I hope you appreciate that we have had to think about the point, place, rotate on the material, which has a different haptic, and a point, place, rotate on the banana. So your attention to the basics and position of your needle is of vital importance all the way around on this exercise. We're going to continue this story next week as we think about what you do when you stitch in a circle. Well, we have previously looked at stitching in a circle in one plane, and we recognize that across this diagonal, we're stitching into, as a right-hand surgeon, our shoulder here, and therefore have to go to backhand for this point at 4 o'clock, and reverse the process here at 11. What happens then if we think about stitching on a circle and joining tubes? Well, it's like this, isn't it? Okay, your 90 degrees is actually defined at each and every step of the circle. I'm standing here at 6 o'clock. I'm thinking of 12 o'clock, 3, 3 o'clock, and 9 o'clock. Okay, so at each and every stage, the point place rotate is important, and you need to be equidistant from the edge all the way around. But what that means when joining one tube to another, that is the 12, 3, 6, and 9 o'clock. But when joining to another one has to think of it 6 to 6, 3 to 9, and 12 to 12. So they're isomers of each other, and they fold over like that. So think of it as tubes. Then we'll think of these tubes. We've got 12 o'clock there, 9 to 3, 9 to 3, 6 to 6. Okay, see that again. 12 to 12, 9 to 3, 6 to 6, 9 to 3. The other thing is when we're starting to operate and join these together, I line them at 12 o'clock at the top. The point we start stitching is going to be the furthest point away. So imagine that I've now taken this tractor, that's the diagonal. If I point it up, that diagonal, my pen's pointing to the opposite side here. That's the point furthest away from me, okay? And it's that point that is the point where you start the anastomosis, furthest away, there, usually about 4 o'clock. And with all operating, one should think about stitching from deep here towards yourself along the back wall and up over the top towards yourself on the front wall. That way, you're always stitching towards yourself and therefore never going to trip up. There are a number of things to consider in operating when you start joining things together. And when we start joining things together, the two most important things to think about is remembering the vectors from one side to another, and there's absolutely no compromise, despite the fact that you might think stitch, stitch, stitch. Remember, it's set up, stitch, set up, stitch, set up, stitch. The second thing to remember is that you do need to think about your system. We've previously gone through the role of the assistant, and we'll revisit that again. But you can see now that your assistant needs clear instruction, not only where to hold the tension, and the direction of the tension. And they need to be instructed on how to move to complement your moving. This now becomes another level of skill of operating. You're not only focusing on your own stitching, but you need to focus on who is assisting you and how they're assisting as well. Good assistants make good surgeons, and good surgeons make good assistants. And all my colleagues will tell you they really enjoy operating with an assistant that has an appreciation of the fundamental basics of assisting that we will revisit again. Next week, we're going to talk in detail about bowel anastomosis. We'll talk about vascular anastomosis. What we wanted to demonstrate here this evening is the fact that when you start drawing one surface to another, the vectors And the principles apply to the stitch on this side and to the stitch on this side. And there's no compromise because, as we said, we either get a dislocation or slippage, both of which will compromise the join. It's interesting that the carpenters and joiners recognize this as well in respiring wood, the quality of the wood, the quality of the grain, and the direction of the grain as well. All the same applies, to be honest, to surgery and appreciation of the tissues and the grain. I know my colleague and fellow sensei, Prof. Sile, is online and would welcome her to discuss the various points that we've talked about this evening. Prof. Sile, if you're there, do join in.
Hi, Prof. Yeah. Good evening,
Thank you
Prof.
very much. Good evening. How are you?
Yeah, I'm
How
fine.
is
Thank
Brunei?
you. Yeah, thank you, Prof. Yeah. Yes, it's Dr. John mentioned. This is really exemplary session and very dedicated teaching. Thank you so much, Prof. We learn about this concept of parachuting and also the place, point, rotate, with the double arm surgical sutures, we as a OBGYN, I have my junior colleagues joining from Brunei, from Kuala Lumpur. If we can recall those days that when IVF in vitro fertilization, and in tubal reconstruction that we learn from the senior, our teachers, our mentor. This is very, very dedicated kind of surgery using very fine double arm sutures. So I'm really impressed with your using the double arm suture this evening, Prof. Thank you. And we hope we can learn more in the next week, like how you join the dedicated tissues to tissues like vascular anastomosis. Very similar concept like our tubal anastomosis. Thank you.
Of course. When you're joining tube to tube, the important thing is not only do you have to have strength and maintain the integrity, the flexibility, but also your joint should not result in any stricture or narrowing. Because as you, I suppose, in rejoining tubes and tubal strictures, if you get that wrong, then you've got effectively another block, haven't you? So respecting the tissues, the back of the tissues, and people are saying, how tight do you have the tissue? So from your perspective, when you're doing a continuous suture joining ovarian tubes together, how tight do you have the tissue? The sutures, how tight would you do the sutures?
I think that this is very difficult to express how much the strength is there, because what we were taught was as long as it is opposed and no leak, because if you're too tight, then it might cause the necrosis of the tissue as well. Yes.
Indeed.
Yes. And then like the tube is like, it is very tiny and thin wall, but it is constructed with the 3 layers as well. The standard, the mucosa, and the muscularis layer of the tube, and then also the serosa. Our aim that those days, because nowadays we don't do these procedures anymore because it might more harmful to the patients. For example, if rather than they go for IVF. But we have to think about some developing the institutions, where the IVF is not really feasible, and so it's like we still have to learn about these basic the surgical skills. And again, you mentioned about this mucosa and the muscularis layer, then that might cause, if more harm to the patient, that will cause ectopic pregnancy rather than she had a fertility and a fertility resume and pregnancy. So do no harm as well, Prof. Yeah.
Yes, and we'll go on. We'll discuss it next week as we talk about blood vessels and talk about bowel. And to be honest, I've never stitched ovarian tubes. The one question that we had posed is, how tight do you have the sutures? Well, it's a good question. It's like a Goldilocks answer. You can have it too tight or too loose or just right. And
Yes, yeah, appropriate.
How do you appreciate just right? Well, put your hands together. That is just right. Squeeze your fingers together. That is too tight. And a continuous stitch is by definition a strangulating stitch. It's a hemostatic stitch. The other thing to recognize is that during the inflammatory phase of healing, edema is maximal at 2 to 4 days. So although your stitches might look a little on the loose side, in fact, at 3 to 4 days, they're incredibly tight. And if you had them over tight, they're even tighter 3 to 4 days. What's interesting, our fellow sensei, Dr. Sudra, who's a corneal surgeon, it's the other way around. What they do in corneal surgery is they tighten the sutures, because what happens at 3 to 4 days, the drying of the cornea means that the sutures loosen. So they have to have them on the over tight side because the inflammatory process is not there. And in fact, the cornea dries out by 3 to 4 days, and your sutures then become just right. So it's interesting. You have to understand the tissue that you're working on, the physiology of the pathophysiology of the healing process, to ensure that your joint is stable, functional, flexible, and also there's no obstruction to it at all, whether it's a vessel, bowel, or ovarian tube. But also you can't afford to have a corneal transplant with sutures that are too loose or too tight either. So the answer to the question, what is the perfect tightness? Well, I don't know if you can actually teach it. I think you have to feel it. And therefore, in feeling, you need to actually practice. And that's why we advocate the banana and tissue, because that is giving you the haptic feel, and it will tell you when you've overdone it as well. Very few models that are available can give you that degree of immediate feedback. What's interesting, I'm using these teaching principles with the cardiac master students here at the University of Malaya, and I'm delighted that one of them has been doing this now for 6 weeks. He's taken photographs of his banana stitching over the 6 weeks. On our scoring system, he's improved 12%. And I'm even more delighted that he reports that people looking at him in theatre have noticed a significant improvement in his skills. I know this is N=1, but I do believe it does work because I've heard it and seen it with a number of other people. This evening's stitching of the patch to the banana might seem laborious, but it was deliberately so, because I was wanting to point out to you at every stage that it's a consciously conscious stitching that is accurate, that I am having to think point, place, rotate every time. And you do that as you learn, because this then becomes automatic. But as a trainer, teaching somebody to do these skills, I would ask them to vocalize it as they're doing it, because I can say yes to the correct place, which is demonstrating the space, and I can say yes to the point, which is demonstrating the precision. And therefore, in teaching this, standing opposite a new trainee, we end up in a rhythm. Place, yes, point, yes, stitch, yes, place, yes, point, yes, stitch, yes, yes, playing, well, not stitch, rotate. Yeah. And it ends up as a rhythm. And vocalizing it actually does reinforce it as well. So your observations, Prof. Sile, are very valuable, and we will compare, contrast. Well, it's not compare and contrast. Compare the stitching of a variant to bow and to vascular material. Any questions from the audience who have joined us this evening? Very happy to take questions from anybody. Any observations? Remember, we do value your feedback, and we're grateful if you answer the feedback that's now in the chat. We do have CPD certificates, and we've had a long discussion about who gets the certificates. To actually encourage participation, I would like to see those people who have answered the questions before the session, and those people who have actually spent more than 20 minutes on the live session get the feedback. I don't think we could hand out certificates for people who just drop in and drop out. The platform I echo, Dr. Apajita, confirms that we have this data. So all of you who have actually followed us so far, who've been on the program for more than 20 minutes and have answered 20 minutes, will get a certificate. And in future, we'll make it conditional that you answer the questions beforehand. Because the important thing is, I'd like you to think about it before we deliver the session. So I look forward to seeing you next week. Please pass the word around. Thank you, Prof. Seeley, for joining us this evening. Thank you to, wow, very loyal audience, Dr. Rudd. I wish him a belated happy birthday and hope he had a good time down in the West Country. And we look forward to seeing you next week. Thank you very much indeed. Thank you, Dr. Apajita.
Thank you so much, Prof. David.